Hi, Doc. Everyone is in. We can start.
Okay, thanks. Good evening, colleagues, and we apologize for the late start tonight. We had some other matters that held us up before we could connect to this webinar this evening. And before we start this webinar, see there are many people coming in. Thank you for those who called me and say that they are waiting to be let in. We apologize for that, but now you are in and we're expecting many more people to join us. We will continue with our webinar. But just to indicate that today, in the medical fraternity, it was a sad day, as we laid to rest one of the stalwarts in our country, Professor Muchichi Mokokong, Sam Mokokong, popularly known as Sam, this morning in a provincial funeral attended by the Premier of Gauteng and the former president of the country and several other ministers. He was a renowned neurosurgeon who cut his teeth at the University of Natal, currently KZN, doing his MBCHB, and also then became a neurosurgeon, MMed, and also a fellow of the College of Surgeons. And he was the first Black neurosurgeon in the country. He worked at Christian Barra Hospital, and they did the first surgery to operate on the Siamese twins, the famous twins that were twins that were at Barra, under the leadership and guidance of a world-renowned surgeon, Professor Ben Cousins from the US. And ever since then, he has been instrumental in training many neurosurgeons in the country. And he passed on last week, and so he was late to rest today. So we just want to dedicate this webinar this evening to Professor Muchichi Sam Mokokong, someone who has been very close to us. He taught us at medical school, and a close relative of one of the other stalwarts, Professor E.T. Mokokong, Ifrentiwedi Mokokong, who's an obstetrician and gynecologist. I don't know if Professor Adam has had any contact with him, and you must have had him. They've been exposed to him in the training as an obstetrician and gynecologist. So we say, may his soul rest in peace, and we are with the family, Mokokong family and his wife, and all the colleagues who have worked with him in the many years that have passed on. And so this evening, then, we continue with our webinars hosted by Clinics Health Group, and we should note that these webinars are CP accredited, and they are also streamed live on YouTube. So at any time, colleagues may be able to access these talks on YouTube. And we'll check with Professor Adam if she will be able to share the presentations, because from time to time people request that we give them the copies of the presentations. And as discussed last week, we can only share PDF copies and not the PowerPoint presentations as they are, because we respect the time taken by the colleagues to prepare presentation for us. And so this evening, the talk is on patient blood management by Professor Yasmin Adam, who's an obstetrician and gynecologist, currently working at Christian Barra Academic Hospital as head of department, and also as an academic head at the University of the Witwatersrand. Her publications are mainly in the field of prevention of cervical cancer, as we've seen in the CV that we've shared with you, that she has supervised more than 40 MMed, including MSCs, and she's an internal and external graduate and postgraduate examiner, actively involved in undergraduate and postgraduate teaching at the university. She's strongly involved in clinical audits, risk management, research and development, information management, and clinical effectiveness. And she has developed and contributed guidelines and has been actively involved in community interaction, giving talks at health awareness events as an invited guest speaker. She is also a member of the clinic's clinical risk committee. And so we are glad to have you once more, Prof. Adam, for your time and dedication to clinics and also to the medical fraternity. And for the time that you're taking to share with us the knowledge and experience that you've obtained over the years in clinical management and academic training. Thank you very much.
Thank you very much, Dr. Lila, for the introduction. I also would like to thank you for inviting me to do this talk. And I am pleased that this webinar is in the name of Professor Sam. So a giant has fallen. So I'm talking about patient blood management. And I'm going to start off just by introducing, what the problem is in South Africa in terms of anemia, the prevalence of anemia, and then look at some of the comparisons between a restricted blood transfusion versus a liberal blood transfusion strategy. A restricted blood transfusion strategy is one where the trigger to give blood is 7 grams percent or 7 grams per deciliter, and a liberal blood transfusion is when you activate blood.
We're losing you a little bit in terms of the volume.
9-10 grams
Yeah, I'll
per
say the volume.
deciliter.
We're losing a little bit. Yeah, sure.
Is that better? Okay. So, and
Yeah,
then I
that's
would
much
look
better.
at the evidence that assists to look at patient blood management, and then about the Matrix, which is a program on patient blood management that was developed by the Western Australian Patient-Based Management Foundation. And then look at it particularly in obstetrics, and then a little bit about what we need to do in terms of consent. So the prevalence of anemia in South Africa in females is about 31%. In males, it's 17%. The prevalence of anemia in sub-Saharan Africa is around about 40%. So ours is a little bit low, but we also have a problem with chronic diseases in terms of giving us this high prevalence of anemia. Blood is not cheap, and it's really a scarce resource, and also particularly if we consider that only 1% of South Africans are blood donors. It's clear that there is a dose-dependent relationship between transfusion and adverse outcomes, and I'm going to talk to you a little bit about that. So in 1999 already, there was the TRIC trial, which was a randomized control trial of non-bleeding euvolemic critically ill patients who were randomized to a restricted blood transfusion strategy, which, as I said, is a hemoglobin of less than 7, versus a liberal blood transfusion strategy of 10 milligrams per deciliter in that study. And what they showed was that not only was the restricted strategy beneficial, it was also safe for the patients. Subsequently, there's been a meta-analysis of about 31 trials and just over 12,000 patients in those trials. And they also showed no difference in outcomes between a restricted blood policy and strategy versus a liberal transfusion strategy. So that is, important information. The next slide, please. Come with the next slide. Thank you. So then there was a recommendation, so a guideline drawn up by the Critical Care Society in South Africa. And what they did was that they started off by looking at a Delphi analysis, and they then had a roundtable analysis to look at all of the information and all of the studies and then they provided recommendations. Now, these were in critically ill patients, and most of us don't deal with critically ill patients. So it's important, I think, that if it's fine for critically ill patients, that may be easy to then generalize to other patients that we see in surgery and also in obstetrics and gynecology. So when they looked at critically ill patients, just generally, they found that a restricted blood transfusion strategy is equivalent and may be superior to a liberal blood transfusion strategy. And in this case, the liberal blood transfusion strategy was where the trigger to order blood was 9 grams per deciliter. The only issue that they found was that in cancer patients, it showed that the mortality was lower in patients where a liberal blood transfusion strategy was used. But they came to the conclusion that this was not sufficient information and that you needed more information in order to know what the trigger is in critically ill patients with cancer. And so that would mean that you would need to individualize in those patients to know whether you're going to, what trigger you're going to use to administer blood. So the studies that they looked at for this particular, looking at the generally critically ill patients, there were cohort studies, randomized controlled studies, and also a meta-analysis. The next slide, please. So the next one that they looked at was the previous slide. Yes, thank you. So the next the next problem that we often see is sepsis and septic shock. And when we have patients with sepsis, we always consider that there's a physiological benefit of giving blood just because of because of oxygen delivery to tissues. And so when they looked at the studies that looked at what the trigger should be for ordering blood in the septic or patient with septic shock, they found that there was neither benefit nor harm when they compared the two strategies. They also found that there was no impact on mortality. There were financial implications in that with less blood, it would be cheaper. Then they looked, the liberal strategies they found may increase the occurrence of nosocomial infection, lung injury, and acute kidney injury. So this was based on a systematic review of 12 cohort studies and one randomized control trial. So good evidence that you even with sepsis, you don't need to use a liberal blood transfusion strategy. Acute coronary syndromes, we know that anemia is common and also associated with worse outcomes in patients who have got acute coronary syndromes. But the question of whether this is causative or just an association was not clear. And so they therefore said that in this case, the trigger for blood transfusion, the trigger for blood transfusion should be individualized for those patients. So after that, in about 2010, the WHO and many of the societies were looking towards patient blood management where a restricted blood policy would be instituted rather than a liberal blood transfusion policy. So they compared in over 600,000 patients that the outcomes in patients where there's a restricted blood transfusion strategy, like in 2013, 2014, versus a liberal transfusion policy, which happened in about 2008, 2009. One of the outcomes was inpatient mortality, and they found that there was a reduction of 27% when a restricted blood transfusion strategy was used. Hospital-acquired infections were reduced by 22% in patients with a restricted blood transfusion, and acquired myocardial infarction or stroke was reduced by 31% in patients within the restricted group. The length of hospital stay was reduced by 15% in the restricted blood transfusion group, but the all-cause emergency admission, readmission was increased by 6% in the patients with the restricted blood transfusion strategy. Then program indicators, one of the program indicators was to look at single unit transfusion. So the recommendation is that you should give a single unit and re-evaluate the patient and then look at giving a second unit. And that the single unit had increased by from 33% to more than expected with restricted blood transfusion. So then we know that blood transfusions have got a risk. And this is from the SAMJ, which is also going towards a guideline for looking at patient blood transfusion strategies. And the risks of red cell sensitization, an increased risk for hemolytic transfusion reaction and hemolytic disease of the newborn was 1 in 13. For febrile non-hemolytic transfusion reaction per pool of platelets, those were platelets, but it was 1 in 20. The transfusion associated with circulatory overload happened in 1 in 100. Urticaria occurred in 1 in 100 patients who got blood. Febrile non-hemolytic transfusion reaction per blood cell unit transfused was 1 in 300. And then delayed hemolytic transfusion reaction occurred in 1 in 7,000. Transfusion-related acute lung injury occurred in 1 in 10,000. And serious allergic reactions occurred in 1 in 40,000. Hepatitis C happened in 1 in 13 million. Hepatitis B in 1 in 7.5 million, and HIV infection occurred in 1 in 21 million. So when we look at infection in the South African Blood Transfusion Service, their side effects or their risks with infection was quoted as 0 in 100,000. So our blood is safe, but there are risks and complications. The complications in the last 6 months at Chris Hani Barra from blood transfusions was there were no associated dyspnea, but the severe allergic reactions occurred in 3 patients. Febrile non-hemolytic transfusion reactions occurred in 3 patients, and unclassified reactions occurred in 3, and hypotensive reactions occurred in 4. And this was in the 6 months. Next slide, please. So then the financial implications. So research on patient blood management has shown that the total associated cost for transfusions are 3 to 4 times the actual cost of the blood bill. So when we look at it, we just look at the cost of the red cells. We don't look at the cost of transporting it. We don't look at the cost of the complications and the monitoring and the administration. Those are just hidden somewhere. We only look at the cost of the unit. So then if you look at what we look at in 2022, the number of the bill for Chris Hani Barra was very high in terms of in terms of the total number was over 26,000, and of those about 1/3 were from obstetrics and gynae. So obstetrics and gynae is a high user of blood transfusion, but we're not the highest generally. And so it's generally surgery and medicine, and then obstetrics and gynecology. Next slide, please. So now then, to come to what we are talking about, what we talk about when we talk about patient blood management program. And the International Federation for Patient Blood Management describes it as patient blood management is the application of evidence-based practices to optimize patient outcomes by managing and preserving the patient's own blood. So there are 3 pillars on which this rests. And the one is optimizing erythropoiesis, which is red cell mass. The second one is minimizing blood loss. And the third one is optimizing physiological reserves. So each one of these pillars are divided into a pre-op, an operative, and a post-op phase. And I'm going to go into those. But in the next slide, I want to just show you that this is what it looks like. So each of the pillars are divided into the pre-op, what you can do intra-op, and what you can do post-op. So I've broken it down in the next slide because you can't really read this. I just wanted to show you what the matrix looks like. So in the South African SAMJ, they haven't redone a different matrix. They've used the matrix which was developed by the Western Australian Patient Blood Management group. So pre-op, the first one is to detect anemia. And in obstetrics, we do this very well, and we're given the opportunity as we do a hemoglobin when the patient is just booked, and we repeat the hemoglobin at about 28 weeks of pregnancy. In other countries, they would do a full blood count at their first visit and then repeat it. And in some other associations, they do a hemoglobin and a ferritin. But we just do a hemoglobin. Then if you've got anemia, then that needs to be investigated, and you need to find out what is causing the anemia. And it may be important to refer the patient to a physician or a hematologist in working out what the cause, and also in terms of treating the anemia. Treat suboptimal iron deficiency and other hematinic deficiencies preoperatively. Anemia is a contraindication to elective surgery. Then intra-op, time your surgery with the hematological optimization. So if you've got a patient who is got bleeding fibroids, this patient is going to become anemic if you don't treat the menorrhagia either with pharmacological agents or with other treatment methods. So if you are going to operate on such a patient, optimize the patient first before you go to surgery. Post-operatively, also optimize erythropoiesis. So you need to look at what the hemoglobin is post-operatively. Generally, the nadir of the hemoglobin will be 48 hours later. I'm not saying that you must wait 48 hours to do a hemoglobin, but you may have to do it earlier, but you do need to optimize it. Beware of drug interactions that increase anemia in the post-op. So then the next pillar is minimizing blood loss and bleeding. So identify and manage bleeding risk. So if you've got a patient who's on Clexane or a patient who's on warfarin, then you really need to manage this patient around the time that they're going to be delivered. Or if you're going to do an operative procedure, you need to plan and work out when you're going to stop it, at what PI or PTT you're going to operate on the patient, and how you're going to put the patient back on their anticoagulants after that. Minimize iatrogenic blood loss. So really, I mean, I think that you do need to consider that taking blood from patients in huge amounts may contribute to anemia. Procedure planning and rehearsal. So if you've got a large fibroid, you must plan your procedure. So you need to think about whether you need to give a GnRH analog, whether you need to give progestogen antagonists, and or whether you need to have a trauma surgeon on standby should you have a big blood loss. And if you have the other one is if you have a patient that has got placental invasion or placenta accreta syndrome, then you do need to plan. So also there needs to be a rehearsal. So if you are going to do such surgery, you need to have an MDT with everybody involved. You need to know that when that patient has a complication whilst waiting in the ward, who will be called out to do the surgery. And generally it needs to be the most senior surgeon that will go out to do that. And in those cases, when these happen in the middle of the night, then it's the senior anesthetist that gets called out as well, and the senior surgeon. You also need to plan your procedure in terms of if you think that the bleeding is going to be more than 20% of the blood volume, or if you don't know, like in a placenta previa, then you should plan for using autologous blood options intraoperatively. And this needs to be done in advance because it takes somebody who knows how to set up the system, and you need to know who to call out. So you're calling out the pediatrician, and you're calling out everybody that needs to be involved with that case. So some of the PAS cases have taken us preoperatively, it's taken us 2 hours just to get the patient into theatre. So particularly when we think there's bladder involvement or involvement of another organ. So then everybody has to be involved. We also would sometimes put in a balloon for the internal iliac, and also put in one of these balloons into the aorta in some cases. But if you don't have those, you do need to plan to get a surgeon who can come and cross-clamp the aorta for you. Intraoperatively, the surgical devices that I've just mentioned, these sometimes need to be placed preoperatively just before the procedure. They are not without complications, but they are better than all the blood that you would end up giving the patients. Then, of course, anesthetic blood conserving strategies. These may be pharmacologic or other conserving strategies. Autologous blood options, so cell savers, and maintaining normothermia. And then pharmacologic agents, I think, in terms of prevention in obstetrics. So with the delivery of the head, you do need to of the anterior shoulder, you should be already giving the syntocinon and then an adequate syntocinon dose afterwards. And then, of course, hemostatic agents. As soon as you think that you're going to have a postpartum hemorrhage, then you do need to use hemostatic agents, and some of them would be, one of the pharmacological ones would be tranexamic acid, and we don't use those for prevention. We use those for treatment. Post-op bleeding, you need to be vigilant in a patient where there's been a problem, and also also when you don't expect the bleeding, you oftentimes may get bleeding. So the management of a patient has to be, you have to have monitoring for every 5 minutes for the first 15 minutes, and thereafter 15 minutes, and thereafter half an hour until you get past the 4-hour mark. Normothermia in the post-op patient, And then also minimizing iatrogenic blood loss is important. Autologous salvage. I know that looking at all the blood in the drapes and all of that have been used by orthopedic surgeons, and your anticoagulation management depends on the type of anesthetic that was used, and it also depends on how important it is to start the anticoagulation within 6 hours or 12 hours. And if you are concerned that there may be bleeding, then you need to go with an anticoagulant that you are very happy to reverse. So, and also, if you are concerned that you haven't been that there may still be bleeding later, and you have to anticoagulate, then you should start with something like heparin and not a low molecular weight heparins, just because you can reverse those quicker. Prophylaxis of upper GIT bleeding, particularly in the really sick patient, and you must treat infections and look out for infections. So the next slide, please. Kamo, the next slide, please. Thank you. So then the third pillar is to harness and optimize physiological reserve. So pre-op physiological reserve and risk factors. So you have to consider the patient's comorbidities and the patient's physiological reserve before you go to theatre. And you have to estimate what you think the blood loss is going to be in that patient and whether that patient will tolerate the blood loss. Formulate patient-specific management plans to get, and that must be dependent on their comorbidities and also on the type of surgery that you're going to go and do, and also think about what your blood loss is going to be. Intraoperatively optimize the cardiac output and optimize ventilation and oxygenation. Post-op, you must optimize your anemia reserve, maximize oxygen delivery, minimize oxygen consumption. So think about all the things that may increase your oxygen consumption. Avoid and treat infections because those are going to reduce erythropoiesis. And also, once you've got a patient that is no longer bleeding, you need to go towards a restrictive blood transfusion and then look at those thresholds. The next slide, please. Okay, so this is the recommendations that were in the SAMJ guideline. And what it says is that once you've got a hemodynamically stable patient, then the trigger for ordering blood would be less than 7. And there's strong evidence for that. If you've got a patient with pre-existing cardiovascular disease, they suggest a trigger of 8. And there is weak evidence for that. And when we look at weak evidence, then we need to say we need to individualize for those patients. And you need to discuss with physicians and hematologists and critical care specialists. Acute coronary syndromes and traumatic brain injury, there's not a lot of evidence. And there is a study that looks at traumatic brain injury that I don't know the results of yet, but for now, we're looking at a trigger of between 8 and 10. Then in the hemodynamically stable GIT bleeding patient, also a hemoglobin level of 7 grams per deciliter. So that's, again, also strong evidence. The next slide. So this is this is a report from SANBIS, which was presented to us at our plenary in 2023, and where we look at everything that we've done over the year. And so the trigger for blood transfusion has been going down, and we are sitting with a lower trigger. If you look department by department, the physicians their trigger is around about between 6 and 7, which is good. In obstetrics, we are between 7 and 8, and in general surgery, it's higher. And that's mainly because of trauma. But that's just in terms of ordering, and just so they look at they have a fact sheet which they bring out, and which is a report on patient blood management. The next slide, please. So what about in obstetrics? So I've talked about a lot of it already in obstetrics, but in obstetrics, you do need to differentiate between the actively bleeding patient and the non-actively bleeding patient. But part of the resuscitation is to stop the bleeding. And I haven't said this, but and it's extremely important to prevent the bleeding. So quantifying the blood loss, you need to look at the blood on the floor, on the drapes, in the bed, in the suction bottles, and all of those need to add up. But and all of that, including the hemoglobin and the hematocrit. The hemoglobin and the hematocrit on their own is insufficient. Just to remember that you do need to look at the base deficit, but that a base deficit of -3 is physiological in the pregnant patient. A raised lactate together with an increase in base deficit does mean that you need to give oxygen carrying capacity, so red cells. In the non-active bleeding patient who is compensated and is hemodynamically stable, you need to look at a restrictive blood transfusion. So we do have patients who come in with an abruption and with a baby, a dead baby. An abruption and a dead baby means that there's 100% abruption. So we assume that the blood loss in those patients are 2.5. So then we activate a massive blood transfusion protocol, which is 1:1:1. So it's blood, platelets, and plasma. But once we've stabilized the patient, we can often send blood back. So you can order the blood, and if you order the blood in a BRB, once you've stabilized the patient and you know she's not going to continue bleeding, and you've got so your trigger would be 7, but you don't, your aim does not have to be much higher than that. So we suggest that we use a trigger of 7 to order the blood. And if it's in a bleeding patient, then we do order the blood, and we order massive amounts of blood, but we then give 1:1 until we have a stabilized patient, and then we send back the blood. So even with a massive blood transfusion, we're now ordering half in a BRB box. Next, please. So the decision to administer red blood cells transfusion in the postpartum must be considered on the amount that they are bleeding. And this is from a UK guideline where they suggest that it can be appropriate to only order blood when the hemoglobin level is below 6. And if the hemoglobin is between 7 and 9, you should consider giving intravenous iron. And if the hemoglobin is more than 9, then you should give oral iron. And certainly, if you're going to order blood, if the hemoglobin is less than 6, but if the hemoglobin is between 7 and 9, and there are symptoms of anemia, then are severe, then you do need to give blood. But you also have you've got how much of blood has the patient got in her bed or has bled, and you also have a blood gas to assist you in terms of ordering the blood. And if you need to order the blood, you must order the blood, but consider ordering it in a BRB because you can give it back. So over New Year and Christmas, I know that there was a shortage, there was a problem with getting blood, and we all get our blood from Sanbus. So we all should be looking after this precious resource. And then I just want to say it must be 1 unit at a time, particularly in the non-bleeding patient. And when I was a registrar, we were told that when you ordered blood, you ordered 2 units at a time. Otherwise, you didn't need to order it at all. And now we have reached the point where 50% of our blood orders to the blood bank at Barra is is only 1 unit at a time in 50% of cases. So that's good. Then you do need to have an informed consent, consider the refusal of blood transfusion, discuss the risks, discuss the alternatives. There must be a clinical indication if you're going to transfuse a patient. Then the person who starts the transfusion must verify the person's details and also look at the expiry date. I'm not sure about the nursing scope of practice, and I've just put it there as a question, and whether it's okay for a nurse practitioner to start to the first unit of blood. Emergency blood is different, and the recommendation is that you have 2 units of emergency blood if you are have got obstetric services, unless you are very close to a blood bank. We are very close to a blood bank, but we still have emergency blood in our fridge in our obstetrics theatre. All transfusion reactions should be reported to SANBIS, and all unused blood should be returned. Next. So then I just wanted to show you the consent that we are using at the moment. And I'm just wanting to look at the 4th point, which says that blood products available in South Africa undergo stringent screening and testing. However, there are potential risks associated with transfusing the above products, such as, and then you need to go through all of those. So I think it's extremely important that you have a consent for blood transfusion. The next one, next slide, please. And those are my references. Thank you very much.
Thanks a lot, Professor Adam, for taking us through this important usage of what I would say it's quite a scarce resource nowadays because of the blood shortage in the country. Perhaps as one of encouraging, I know that these practitioners here, and from time to time, 1 or 2 of us will be in a situation where they've got to make a request for a blood transfusion, that we ourselves can also become blood donors. So I don't know how many of our colleagues here who are on the SANBIS database as those who get reminders to donate blood. I just got a reminder now just after Christmas to say there's a shortage, as you just indicated, there's a shortage of blood and there should be a donated blood. And I'm a blood donor myself, so maybe if many of us can do the same thing to donate blood. You asked, I'll just stop it. Colleagues, please do not hesitate to post your questions in the chat group. And if you want to ask a question, please do also raise your hands if you are not here. Raise your hand if you are not able to post your question on the chat group. You asked a question about the person who initiates the blood transfusion and whether is this included in the scope of practice for nurses? I would also want to pose this question. If there are any nurses out there, if they want to comment, please do comment on this in terms of your own scope of practice as to whether this is it's something that you are it's included in your scope of practice. And also related to blood loss, you quantifying. This seems to be quite a problem sometimes as to how do you quantify. You said you look at the blood soaked drapes, you look at on the floor and also when it rains and so on. Is a guideline that nurses can follow, or even doctors, surgeons, and anesthetists to quantify blood loss? It's a rule of thumb to say when you look at this, the swabs, will this have to indicate the certain amount of blood loss? Maybe you can comment on the second one while we're waiting for the nurse. It is one. You're muted, Prof. Adam.
Oh, sorry, I missed that. What was the question?
The quantifying the blood loss. You mentioned several factors that one can look at, but maybe when you look at those, well, maybe is there a specific guideline as to how do you then measure or quantify the blood loss, looking at all those different areas or garments or types of.
So, Dr. Bila, generally, if the blood is just in the bed, then you're looking at about between 500 and 750. If the blood goes from the bed and is onto the floor, then you're close to 1,500 mils. If you've got a pool of between 50 centimeters to a meter, you're looking at 2 liters. But you also have the blood pressure and the pulse. So the physiological changes in a pregnant woman is such that a pregnant woman can lose a liter of blood and the pulse and the blood pressure remains completely normal. And then they bleed some more, and suddenly they reach a point where they decompensate. And so if the pulse is between 100 and 120, then you're looking at a blood loss of 1.5 liters. If your pulse is greater than 120 and you're going to a pulse of 140, you're looking at a blood loss of 2 liters. And thereafter, if you're dropping your blood pressure together with a tachycardia of more than 140, you're going to a blood loss of 2.5. So that's on the one hand. So it's the pulse, the blood pressure, and then, of course, the amount of blood that has been there. The hemoglobin and hematocrit on their own are not good enough. And then the other things, the other parameters that you can look at is the base deficit and the lactate.
Thanks a lot.
But your aim shouldn't be to go more than your aim shouldn't be to transfuse more than 8 grams %.
Yeah, I think that's quite important. I think that's the indications of when to transfuse. I think it's a good guideline to follow. Dr. Ngatane, your hand is up. You can unmute yourself and ask your question.
Thank you very much, Professor Adams, and a very good presentation. I think you raised a certain important aspect. Now, sometimes one deals with people with religious beliefs and things like Jehovah's Witness specifically, where when there's a need for the blood, they will not want to take the blood, and one has to make a decision whether to go ahead with the surgery or not. The second aspect that you raised, which is very important for me, is the issue of the consent. Now, if you already have someone who has been booked for surgery, and as part of the discussion with the patient, you mentioned that you might have to give you blood. Let's say you do a myomectomy, so you might have to give you blood and things like that. Now, at what stage do you, at that stage, have to get the consent for the blood, or is the consent only for someone who is getting elective blood, or I assume if someone is decompensating or something like that, you might want to give. But my worry is, at what stage do you get the consent? The third aspect is the scope of work for the nurses, because I think the common thread is where the nurses are asked to start the blood transfusion whilst the surgeon, or maybe they say the surgeon is in the ward, the blood comes in while the surgeon is still in theater, and then the ward phones and said the blood has arrived. Do you wait before, as a surgeon, or before, until you come out of theater, or you like to have the blood started? So those are a bit of a concerns that one probably could be faced with. Thank you. And as you said, Dr. Bila, in your opening about Dr. Mokhokong, Professor Mokhokong, it very sad. And funny enough, we matriculated at the same school, Orlando West High School in Soweto.
And taught by my father-in-law. I had to put that one in.
So, thank you very much,
No,
Dr.
thanks for the comment, Dr. Ngatani. And Professor Adam?
So thanks very much, Dr. Natani. So I think the first one is in terms of somebody who won't take blood. So I guess it depends on the kind of surgery and what you think you're going to do in that surgery. And if you can, so think the pre-op management in those patients would be to see whether you can get the hemoglobin up to about 12 prior to your operation, and whether you give erythropoietin together with iron, but that's one of the options. The second thing is, I think that the Jehovah's Witnesses don't all fit into the same box. So you'll get some of them that will say, no, I will take my own blood. And there is an option if you, particularly in a pregnant patient who you know is going to have a problem later on, you can take a unit of blood from them, which can be stored for the patient. So that would be the one thing. And then, of course, you've got the cell saver. But there are many of them who will not even take the blood from a cell saver. Then you've got you've also got patients who say, but that's fine. If you give me the blood in a private room, that's okay. So there's all of that range. But at the end of the day, you have to discuss with the patient. I think if you think there's going to be a 20%, you're going to lose 20% of your blood volume during that operation, then you do need to discuss blood transfusion with the patient. So in the consent before that, although if you have a patient on the table and you need to give blood in an emergency, you can give that blood unless that patient has got a directive which says they will not take blood. So if there's no directive and you are called to this bleeding patient who is unconscious and you give blood, then that is still within our law acceptable. So that's as far as the Jehovah's Witness is concerned, and the consent to give blood also. What was your other questions? Too many questions, Peter.
Jasmine, it's
Yes.
not the one was also the scope of work for the nurses. That
yes.
Let's say because the idea is for let's say the surgeon or the doctor to start the first unit. Then I'm saying that because of sometimes we have the delay where the patient needed blood, but we're waiting for the blood to come from the blood bank, and by the time the blood comes in, you are busy in theater. Do you wait, depending of course what type of surgery you are doing, do you wait until, or what will be the acceptable situation to say nurses, someone must start the transfusion? Because those sometimes are the gray area. Someone has been bleeding, you ordered blood urgently, and the blood comes in whilst you are still busy and not able to come to this thing.
So that for me, I think, is an emergency. And so if the nurse is asked to start that, then I think that would be acceptable.
There's someone who wants to answer that question. Trudino Seke, she is a nurse and also has got a relationship with the nursing council. Trudy, you can unmute yourself. No, she said she can assist with this question. I see I don't know if you can unmute. Okay, go ahead. Yeah, go ahead, Trudy.
Sorry, Dr. Peter. As I said, I will attempt to answer the question because it's related to the scope of practice of nurses. And I think someone has partly answered or maybe complicated the question. First of all, let me appreciate the presentation from Prof. I had my own questions to ask, but I will try and attempt this one. I think the challenge that is the nurses are supposed to maintain an IV line once it is initiated. And nurses, when there's an emergency, they can actually initiate an IV line. This is what they are allowed to do. But when it comes to blood transfusion, I think as I was listening to Prof, before you initiate blood, there are certain things that you need to make sure that they are there. And also, so the challenge then for that particular whatever job or task to be left to nurses, it rises when where there's no emergency, of course. It rises when complications happen. And I am going to talk like someone who has dealt with such complications where the nurses will end up taking a blame for something that could have been done by someone who is much more trained to deal with the situation. And it sort of complicates a lot. Currently, last week we're dealing with a question that was saying, are nurses allowed to be assistant surgeons during operation? Because there's a shortage of doctors. So for me, this is the same question, sort of links there, that why are we even saying the nurses should initiate? Someone will tell me that because the doctor will be busy in theatre and there's not going to be another doctor to do so, which then goes to a lot of levels of discussion. Why are doctors not there? We don't have enough doctors in the country and all sorts of things. But just to try and be direct in this one, as a stance, the nurses shouldn't be the ones who are initiating blood transfusion. There should be a doctor who's there who makes sure that everything's like, the nurse should be the obvious. They will know that when you are putting up blood, there should be someone to witness and everyone. But it cannot be a job that is delegated to nurses, and reasons are given that doctors are busy somewhere else, because I believe the country's got enough doctors. Actually, if we can deal with the other challenges that are there. We see doctors coming on TikTok and everywhere saying that we are here, we are 800, we don't have jobs. So yeah, unfortunately, because nurses, like all other health professionals, are there to save lives. If it's an emergency, I'm sure nurses will actually volunteer to say they're going to do so, but it shouldn't be taken as once blood comes in, if there's a nurse, the nurse must take the blood and put up, because they're going to say, in terms of our scope of practice, we need to maintain the blood once it's in make sure that the patient doesn't have any reactions, record all the other things that needs to be recorded. But in initiating the initial unit should be put up by a medical doctor, who then will hand over to the nurses to take over and continue administering it. I think that's basically how I'm going to answer it. I may not be giving the proper answer, but the bottom line is that it is not a duty of a nurse to initiate blood. However, I think we all understand the principles of ethics. Nurses are not there to cause harm. If this is a life-saving situation, nurses are going to just put their hands on the deck and try and assist. So the defense of we don't have enough medical practitioners, I am not sort of one of those people who appreciate it. I think that's where I'm going to end with this one. But my question, Dr. Pila, to Prof, was, I like the way she was explaining the issue of blood transfusion and maybe on the issue of reactions and how it happens. Especially she was giving us an example with Bara. I wanted to check whether, because Gauteng is also one of the provinces that is actually embedded with a lot of litigations. In the litigations that are happening in Gauteng relating to your maternal deaths and other complications in during labor, has there been a trend or anything that Prof has observed that relates to blood transfusion, or blood transfusion has completely not been involved in any of this? The causes of medical litigations are coming from all other areas, except for the fact that maybe we didn't have enough blood, one, or maybe because there was a reaction to blood transfusion, or maybe because someone didn't give the blood correctly. And if blood does get involved in sort of increasing the numbers of litigations, if that is the situation, how are we, or how can Prof advise that to avoid leading to those situations? This is what can be done when you are dealing with a patient that needs to be transfused. Thank you. Thank you, Dr. Bill.
Can I say, before you respond to that, Prof. Adam, Assistant Mhlongo is also one of the nurse managers at one of the hospitals, wants to delve into this issue of scope of practice for nurses. And Dr. Pai, who's one of obstetricians, also was asking if there's any advice from the nurse council. But I think Trudy Maseko has answered that question, Dr. Opai. Stanley, Mhlongo? And Martin Tezuka from one of the public hospitals also says, no. The initiator of the blood transfusion is the doctor. Stanley? You can unmute yourself, Stanley. Oh, he's a bit shy. Okay, go ahead, Adam, and answer Ms. Kaseka's question about litigations and non-availability of blood.
So we haven't had a patient die from hemorrhage or a patient in the last 3 years. And we haven't had a patient who has died because of directly from blood transfusion. But I want to say this, that the association between infection in a patient who has had a postpartum hemorrhage is there. And so patients, so sepsis is a high cause of maternal death. And I think that's worldwide. And it still is a big cause of maternal deaths in South Africa. Whether those patients had been transfused or not, I don't know. But there are, I think those would be looking way down the line to say how many of these patients had a blood transfusion that now had sepsis and died from sepsis. So we know that relook laparotomies, which are often done because of bleeding, are associated with a blood transfusion. And those patients are also the kind of patients who will get sepsis. And severe sepsis, where we're doing a hysterectomy and who come close to, who have a severe morbidity or even a mortality. So I think it's too simple to just look at a direct relationship. But, I think certainly if you look at the comparison in that Western Australian study, which was more than 605,000 patients, those are huge numbers. And whether those are, one can also say, was it the blood transfusion as a cause? But certainly it was clear that the in-house mortality was less when you use the restricted blood transfusion strategy. But those are statistics, and so statistics help us to talk about populations. They don't always help us to manage our patients as individuals.
Thank you very much for that response, Prof. Adam. I see Stanley is unmuted himself. Stanley, you want to go ahead? And we start with the last comment before we close this discussion, and ask Professor Makunyan if he's still around, just to maybe make last comments before Professor Adam makes a last comment.
Thank you very much, Dr. Bill. I hope I can be heard now. I just wanted to ask, we have seen...
No, we can hear you.
We have seen the leaders from the Jehovah's Witness community presenting to the hospital some regimen of some sort with some treatment, the iron or maybe herbal or whatever. I just don't have the specifics at the moment. So I just wanted to ask Prof, how then do we manage that? Is that acceptable? Obviously, that needs to go to the doctor or the physician involved. to look at and deal with that. But however, just as a matter of the rule, is that then accepted that we get that presented, and then for maybe to follow that regime, obviously in an attempt that the patients will not have the blood transfusion, but follow that regime that they are presenting. Thank you.
So thanks very much. So for many years, they did pay for the erythropoietin that we would use to stimulate red cell formation, and we have had patients where they've done it, but we've also now just used hospital resources if we need to give erythropoietin to increase it. I don't know very much about the herbal pot that you're talking about, but I know that they also suggest that we use these other oxygen carrying fluids. So I think it's called the Hemocure, and those they are fine in an absolute emergency, but they do not help when you really need to give blood. So those are as far as what we have, but I don't really know the evidence, Stanley, for the herbs and the other things that they talk about, but certainly erythropoietin together with iron we have used.
Okay, thanks, Stanley, for that question. Yeah, I think it's a difficult one, but I think there have been cases where we understand how they communicate with the doctors. Professor Makunyane, I don't know if you're still there, if you have got last words to make. Oh, just to get by surprise. Okay, thank you. From your side,
Oh, okay, sorry.
There. Yeah, thank you. Go ahead, please.
Okay. Yeah. No, I was about to say that this is a very interesting topic, even though, in ophthalmology per se, we are not really high blood users. However, what I'm curious about is how Baragwanath, for instance, could be controlling. I know that the blood use can be one of the highest cost drivers in a hospital, mainly because these are now teaching hospitals with doctors at various levels, interns, medical officers, and being able to can order blood, and therefore wastage become an issue and becomes a cost driver. How is that curbed in Baragwanath Hospital, for instance? That's the question I had for Professor Adam.
Thanks very much, Prof. Makunyane. So I was looking at, when I was preparing for this talk, I was looking at the information that we got from SANBIS in our last plenary, which was 2023. And Baragwanath was one of the hospitals with the best cancellation and the least wastage if you compared us to the other central hospitals. So that was the one thing. I think that the blood management, what I didn't talk about in terms of patient blood management, is that you need to work together with everybody that you work with. So it's midwives, it's anesthetists, and of course the doctors that work together. So and then you need to be able to come up with an agreed principle of how you would and when you would use blood. So I know that one of our doctors who works with the, who works in the blood ordering, and she's our liaison for blood, Dr. Adam, she you know, so there are meetings all the time, and with meeting together with setting up meetings with anesthetists, we are able to get to the point where we agree on how we're going to go forward. So, I mean, I think our bill, I think just for obstetrics and gynecology, our bill was 15 million last year. But when I showed you the trigger at which we use blood, that was for our department. So we're sitting in, you know, we look like we're ordering blood at below 6. Of course, there are other factors, and certainly together with physicians, if we do have other issues. So, you know, if we say, well, no, this patient, we're not happy with the hemoglobin of 9, but then it would be physicians or hematologists that would want us to transfuse. So the blood management, it was actually Sanbus who started these discussions. And at one of the meetings that we had with them, they suggested that the different departments meet, you know, with all the people that you work with. So all the role players in your department, to work out how you're going to go forward and do that. And it took us a long time before we actually did sit down and meet and get to the point where we do this. So our 15 million it's not just obstetrics. In fact, obstetrics is probably only 1/3 of that. The others are from gynae and from you know, the gynae outpatient department. So those are the ectopics and the miscarriages and those patients who are also really, really ill. But I didn't know how good we had done as a hospital. So we were sitting at about 100%. I was shocked to see that number at 100% in terms of not wasting a certain amount. And then the other hospitals, I think, were sitting at 60% compliance, 70% compliance. But there's a big, I mean, I think it's people like all the people who work, you know, within from all the departments that come together to work on in the blood, together with the blood bank. So it's including management that sit on this group.
That's good. So it's the whole team working together to manage and save costs. Because blood products is quite a huge bill in the cost of managing a tertiary hospital or a central hospital. Thank you very much. Any last words from your side before we come to the end of this presentation? Wonderful. Is there any last word from you, Prof. Adam?
I keep on muting myself. No, thank you very much. And thank you for inviting me. And thank you for the questions, everyone.
Okay. Thank you very much. Yeah, now that it's quite been an informative session and we've gained quite a lot. And I think I like the fact that we're able to involve nurses also in the discussions that we've had this evening, and that we go ahead and make sure that we save blood and we know how to manage patients. I think the guidelines also that we've given as to when to give blood and what, if you don't have to use blood, there are other mechanisms of intervention that we can make to make sure that we still treat our patients safely. And on behalf of Clinics Health Group, I just want to thank you for availing us yourself and being part of the risk committee. The work that you do there, it's amazing that we quite want to acknowledge you for that. And also to thank all the colleagues who joined us this evening, both from the risk committee and all those who are coming from different parts of the country, both public and private and various disciplines, and for being with us every week. We just want to thank you, and we hope that you will join us again next week when you continue these webinars. And to thank Clinics Executive Committee for allowing us to have these webinars every week and funding it, and also to GAMO. And I see Anza has joined us also from the marketing team. thank you very much for helping us to make sure that we bring these webinars to the team, to your colleagues. And may you have a good night and bye-bye. Thank you very much.
Okay, thank you, Kamu. Okay.
Thank you.
Thank you, Prof.
Thank you, Prof.